Good morning and welcome. Welcome to what is the first of our thematic innovation ecosystems on medicines optimization. This is the start of a journey we're hoping with our ecosystems from Ireland, Poland, and beyond as well, on a whole range of topics on the area of medicines optimization. Today's going to be on the subject of polypharmacy. For those people who don't know me, my name is Andy Bleaton. I'm the Communities Director here at the European Connected Health Alliance, the ECH Alliance. I'm going to give a brief introduction about who we are and what we do, and then we're going to go through and start hearing from some of our speakers today. Just for a bit of background about us, the ECH Alliance, we're a not-for-profit organisation, a member organisation, with over 920 now member organisations, most of whom are not-for-profits, government bodies, universities, hospitals, patient groups, carers groups, also companies as well, and regional governments, many like yourselves. Most of them join us because they want to connect up in the field of health. So we use our ecosystems, such as the ones today, to bring our members together so they can collaborate. And that's a global audience of now over 22,000 people from across the globe, all coming together and taking part in a variety of ecosystems, which I'll talk about in a moment. We also do a number of events and support our members, as you would expect with a member organisation. But the vast majority of those members are what we call not-for-profits. They join us usually for free. So we'll put a link in the chat function for you all. If you want to join, please feel free to follow the link. By becoming a member of the ECH Alliance, we get a unique opportunity like today to be able to promote your organisation, your projects, your innovation, but also, and let's not forget this, your needs, because we all have needs where we need either partnership or collaboration or funding or solutions. We can enable that with our community by making direct connections, by helping you get access to our community of ecosystems, but by joining working groups and getting involved with programs such as these thematic innovation ecosystems. What's important now is our members also join us because we provide free information about funding and tenders, discounts on events, free tickets, etc., as well as speaking slot opportunities, which is vital to be able to amplify and expand your message. As I said, the link for joining us will be in the chat function below. For many of you, it'll be free to join if you're a not-for-profit too. It's also worth remembering. But we've been using our ecosystems now for over 11 years to include all the stakeholders you can see in front of you, all of them leading with a need, with patients and citizens at the front and the centre. And we use a concept where we build a multi-stakeholder gathering, which has, or as I said, all of those stakeholders with a focus on matching need on one hand and solution on another. That's what we're going to be doing today. And we do that and try and encourage our organisations to try breaking down some of the silos that are in healthcare, transform healthcare delivery, but also create economic growth. We've built a network of these ecosystems up across the globe that you can see in front of you. Some of them are represented today, so we've got representatives from Scotland and Ireland, from Northern Ireland, Poland. We've got speakers also from the Netherlands and from Belgium too, from one of our projects, BEMA project. But that growth has come despite, probably even because of COVID, as people have sought better ways to collaborate. That insistence from our ecosystems of ways to collaborate is why we've built a series of thematic ecosystems, which are, instead of being geographically based, are thematic, with topic after topic on a certain theme, such as today on medicines optimization, where today we're going to be looking at polypharmacy and following that up with another session on transitions of care. We'll be hearing from some of our projects. We're also involved with many European projects, some of which we'll hear from today. And we've also created our data arm, which is the Digital Health Society. Again, if you're interested in any of those, pop your email in the chat function below and let's start collaborating. But that's enough from me. What I'm going to do now is hand over to our first speaker today, Alpana from Scotland. Please introduce yourself and start sharing your screen. I should talk about the WHO guidelines. the guidance.
Yeah, no, thank you, Andy, and welcome everybody. And thank you for inviting me to speak to you about the Polypharmacy report. If you just give me a second. Okay, I presume you can see that okay?
Yeah.
Yeah, okay. So I'm really going to talk to you about the WHO challenge and how countries might want to consider implementing the key priority action areas focused around addressing medication safety. So as you know, the WHO launched their challenge in 2017 to try and get countries to sign up to reduce avoidable severe medication-related harm by 50% over the duration of 5 years. Now, for various reasons with COVID and other aspects, the challenge is still ongoing, and this year's theme of World Patient Safety Day is also going to be focused around medication safety and medication harm. So just taking a step back, really, why do we need this challenge? Why do we need to address medication safety? We know that the population globally is aging, so many more people are going to be living over the age of 60. Now, this is a good thing because actually public health improvements and socioeconomic developments means that there's increased survival at a younger age, but also at an older age. But what we want to see is healthy aging, and many of you will have been part of the European work on action on healthy aging. And so we want people to age well. We don't want people to age and actually not have healthy life years. So we know that as we get older, and what's shocking about this figure, I think, is you don't actually have to be very old to have, 1 or 2 long-term illnesses, is that more people live with many diseases rather than just a single one. And what tends to happen as a consequence, and on the right-hand side, you can see some national Scottish data. You can see that, again, at a relatively young age, people take many medications. So they're taking upwards of 7 or 8 different medications, which they may be taking 2 or 3 times a day. So they have what we call polypharmacy, which is simply taking multiple medicines. This produces potential for harm and error due to drug interactions and side effects. But also, we know that people themselves will go and buy medications that they take. So things that they'll prescribe for themselves or their neighbours will prescribe for themselves. And as you get older and maybe frailer, if you have lots of long-term conditions, frailty may be an issue, and as might impairment of the liver and the kidneys, which means that you less effectively metabolize the medications and therefore are more prone to the side effects and therefore leading to medication-related harm. So some of the data, if you translate that across Europe, what's quite startling is that 8.6 million admissions every year in Europe due to adverse drug events caused by medications, and half of these are preventable, with 70% of these occurring in people over the age of 65 or more, taking 5 or more medicines. So it's not that many. The other aspect is that if people taking 4 or more medicines, if half of them are also not taking them as prescribed, you have another type of harm here, and due to maybe intentional or non-intentional adherence to medication. So the WHO challenge really sort of tried to build a framework to help countries think about addressing medication related harm and to raise awareness, to develop guidance material, to build capacity for healthcare professionals, and to empower patients and families to play a role, and for policymakers to actually make a commitment to making sure that this work is embedded as part of day-to-day practice. Now, some of these things that obviously Andy discussed in the ecosystem is a great way to build capacity of healthcare professionals in terms of sharing tools and also raising awareness. So the 4 quadrants of the WHO challenge really deal with patients and the public, healthcare professionals, medicines, and systems and practice of medicines. And you can see that even within those, that these are broken down into some specific areas. So for example, leadership and governance is really important when you come to address cultural aspects of colleagues talking to each other when they notice a medication related safety event. And the key action areas that have been chosen because of the problems and the scale of the problems of harm that it can cause are polypharmacy, high-risk situations and transitions of care. I'm going to focus on polypharmacy, but I'm going to also outline how actually the three are interlinked and intertwined. So polypharmacy, I've already said, so this is the report. If you want to access this report from the WHO website, it's medication safety in polypharmacy, and I had the privilege to be the lead author on this report, and it highlights the key elements about appropriate and inappropriate polypharmacy, and also highlights some patient tools that can be used, and I'll cover some of the other tools as well as we go through. So it's important that just because somebody takes lots of medicines doesn't make it always harmful. So it's about getting the right medicines for the individuals, making sure that they're going to be able to take them for long enough to get the benefits. But even if they are taking them, are they achieving what we want to achieve without causing the individual any harm? Where it becomes inappropriate, and it's not dependent on the number, is when some of the medicines prescribed are no longer evidence-based, they're causing harm, or actually the individual isn't going to be able to take them in the way that's needed in order to get the benefits that's been implicated in the trials. So a key methodology that we have is using the 7 steps process by engaging patients in this process and using a person-centered approach. And this is also covered in the WHO report, but actually stems from the work that we've been doing in Scotland, and it's a 7-step process. And you can see the QR code, and you can freely download this information toolkit that's available both for clinicians of all backgrounds and patients. So finding out what's important to the individual patient, and then working out whether we've got the right medicine for the individual, stopping any unnecessary medicines, so stopping any harm. If the medicine's ineffective, again, reviewing that, we maybe need to increase it or reduce it so that we stop those harmful admissions, those 8.6 inappropriate admissions every year due to harmful effects of medicine. And in some countries, we need to think about the cost effectiveness of it. Is this the most appropriate product for the individual? And really importantly, we start with the patient, what matters to the patient. We come right back to the patient because they're the center of this, and agree and share the plan, and making sure that we share it with all the other healthcare professionals involved, because we know that patients touch points with many different healthcare professionals along their journey. So this is the app. If you want to access it, just go to the App Store and you can download it and access the tools that are available to help you address medication safety in this area. So people take many drugs. So how do we focus on some of the medicines that are going to cause the most harm? And this is really where the polypharmacy work links in with the medication safety in high-risk situations. So the report highlights some medicines using the APINCH acronym that are very common in causing medication-related harm in the hospital setting. And you can access this report and get some information. In addition, there's many medicines that have been identified in primary care. And again, you can access the review here using this link for free and access the medicines that are commonly implicated in primary care: non-steroidals, hypnotics, CNS drugs, opioids, painkillers. So you can see that there is an overlap. So if we're thinking about focusing, we might want to look what's going on in our country, in our institution, our hospital, where are we seeing the harm, and use that as a basis to start your work. And again, if you look at this as specific information that also explains to patients and their family what they might get out of a medication review, because we want to ensure fulfilling that patient and family quadrant, that we involve the patients in addressing medication-related harm. So they have the opportunity to look up the individual medications and find out more about them. Now, polypharmacy is a global problem. It's not just a problem of the West, it happens right across the globe. And we see rates of 20 upward% in countries like Africa, India, China, as well as across Europe. And this was just a picture to demonstrate that it can occur at any age. So this is a relatively young women that you can see from a polypharmacy clinic that I ran in rural Uganda, where women were doing trade-offs in terms of, do they buy food or do they buy medicine? And often these were medicines that people didn't need. So really important that we are patients advocates. And one of the things that the app has that you can use to help address this is provide them with the tools, shared decision-making tools that are shown in a pictorial fashion so that patients can make decisions. And hopefully it helps with some of the issues around health literacy as well. We also want to empower patients so that they know what to do when they become ill. And this is one area that has been heightened during COVID when people experience fever, dehydration. So some medicines can cause harm when somebody is dehydrated or unwell, and they may need to stop these temporarily to prevent acute kidney injury. And these are just information can be found in the app, or countries can print little credit card leaflets to give to patients so that they can be reminded. And a clinician may want to add in particular medicines themselves that they identify for patients to stop taking. So these decision-making tools, let me just quickly show you what they look like. So you can see here how easy it is then for a patient to see, actually, it's quite a lot of people that need to take it, and for one to gain benefit, and how does that relate to me? Am I going to be able to take it? Am I prepared to take it in order to get that benefit? And so it's important to have that conversation with the patient so that they can understand it. And this is another one here that's shown for benzodiazepines and hypnotics, which patients often become dependent on, but often do them a lot of harm, and just showing it pictorially really helps. When people are on lots of medications, they move across care transitions. So the medication safety and doing polypharmacy reviews is really important when people cross care transitions to make sure that they are on the right list. So it's important that we address this before we address adherence, so that when people are given medicines or taking medicines, they take the ones that are going to give them benefit and minimize harm. So again, patients have the opportunity to capture their medicine list within the app, but equally remember that if you don't have an app, people could do this equally by having an exercise book or something. And so in Scotland, just, and Mike's going to talk about this, so I'm not going to dwell on it. We obviously led the Sympathy Project, and we're leading the iSympathy Project just now, and so our partners in that. And then we're also supporting Malawi and Zambia start up and address the medication-related harm using the tools and the methodologies that we've just discussed. But how do we go about and make sure that we have a change around medication safety and that it's effective? And one of the key things that we found from Sympathy and that we've applied in iSympathy is really about using change management techniques and making sure that we have a really clear vision of why we need to do this. So creating that urgency about reducing inappropriate admissions to hospital, which can be about 11%, and reducing harm and the treatment burden to the patient. And it's really important that that we engage a multi-stakeholder group so that we get the commitment in order to undertake and deliver this work. So the key findings, the key principles, and again, some of these are picked up in the WHO report and also in the Sympathy Handbook, which I can share with Andy to share with colleagues, is really about when you're designing a system around any aspect of medication safety, make sure that your team is a multidisciplinary team, but you also involve the patient and policymakers so that it's not a project, it's about something that we embed into day-to-day practice, and that's supported with education. Make sure that your culture is one where people can speak up about potential seeing harm or where they think a medication is inappropriate for an individual. And we are the patient's advocate, each one of us. So regardless of the professional background, whether we're a patient or a carer, it's up to us to speak up for the individual patient. And we can take a benchmark. So that's important. If you're going to make a change, find out where you are, use the tools that you've got available to say, well, what are our problems and how are we doing just now? And what do we want to change and by how much? So using the improvement methodology to help you drive that. It's important that you know where you are. And this is just really an example of some of the data, some of the improvements that we've made in terms of high-risk combinations that address medication-related harm in Scotland. And this is data right across Scotland. But there are many other countries, and I've just listed some examples that you can access to get some additional information for. And the other thing that Sympathy found is that it's really important to share tools that you've got and make them available. And so that's what we've done in Scotland. We've made all our tools available, freely accessible, and indeed they've been adopted in Northern Ireland and Ireland so that we can share these tools and scale up. So these are tools, one looking at adherence that we're developing that shows gaps when people aren't taking medication. So it's equally important that we pick up where people could be doing them harm when they're not taking medications. And obviously the guidance that you can download or the app so that you can start implementing change and addressing some of the areas in your own countries. So thank you very much. I think I'm not sure whether we've got time for questions, Andy, or we're going to take them all at the panel discussion at the end. So
going to look at a panel discussion at the end. Thanks. That I think you've nailed in those slides the challenge. I think that's very clear. So I'm really pleased because I think certainly from me, I'm an outsider to this field, but that's clear to me, and I think the challenge is clear, and I think the value and benefit from the resources you've put. I put one of them in the chat function for the 7 steps medication review. I think that's vital. And then if you've got any more to share, and please do share those additional resources, because what we're trying to do with building this community, we are just at the start of this specific community, is we'll host not only the presentations and the videos and the leaflets, etc., but those reports that you mentioned, because I think that we're trying to have that repository. We can put it on our website, we can share it across the community here today, from not only from yourselves in terms of what the challenges are, the picture from Scotland, which is just ideal, but also the WHO challenges as well, but also then what we've got from the project, from our Sympathy project, from Beamer, from Poland, etc., to create that permanent level of resources, so we don't have to reinvent the wheel. Because you can see here, I think, really clear, scalable solutions from Scotland adopted across Northern Ireland, in a way, or vice versa, in a way that shows that we should be much more open to sharing our resources and best practices, because otherwise we're just going to keep going back to the same subject. So thanks for that. I'm conscious you've got to head off to the airport shortly, so we'll take some questions when we do the Q&A. Hopefully we'll come back to you there. I'm trying to keep up with some time, because in the corner of my eye I can see the clock ticking. So we've heard from some of the challenges there. We're going to hand over to Dr. Michael Scott now and hear about the iSympathy programme and in terms of what some of the resources have come from that. So please, the floor is yours. Thank you for that, Alpana.
Thanks, Alpana. Thanks, Andy. I'll just make sure I get this screen shared here.
Whilst we're waiting for that, and if you've got any questions for the panelists, please pop them in the chat function, and then we'll bring them up when we've got our discussion bit right at the end of our session today. So any questions for both Alpana and obviously Mike and colleagues too. Here we go. Something's moving.
Yeah, good. That's good. That's always good, Andy. So let's see. I can get it onto presenter mode.
There you go. You're away.
Okay, grand. So I just introduced myself, Andy. I'm Mike Scott. I'm the director of the Medicines Optimisation Innovation Centre in Northern Ireland, which was set up by the Department of Health in 2015. So four key aims are to focus on the needs of the population of Northern Ireland, to innovate or seamlessly steal innovation from somewhere else and bring it back, to knowledge exchange and collaborate. And we do a lot of work across Europe, particularly in Poland and Estonia and Scandinavia, and also to help the Northern Irish economy. So we do a lot of work with tech companies and pharma. We've arranged with ABPI. So that's the background to NYC. Alpna has highlighted, Alpna is the SRO for the iSympathy project. And Alpna and I first met on the Sympathy program, which was the precursor of iSympathy, which is resumed from that, and also got to know her through the WHO working group on polypharmacy. So just going to quickly talk about that, what we've got in the Northern Ireland section of this. So it's a 3-year EU-funded project running to 2022, operating in Northern Ireland and Scotland, basically in Dumfries and Galloway and the Highlands and Islands. And the border counties of the Republic of Ireland, those are the counties, won't mean anything, maybe most, Donegal, Sligo, Leitrim, Cavan, Monaghan and Louth. Uniqueness is that Northern Ireland is hospital based, so we're utilising the 7 steps methodology in hospital, which hasn't been done before. And in the GP practices in the south of Ireland, they haven't had practice-based pharmacists before. In Northern Ireland and Scotland, we have practice-based pharmacists. So that was a novel intervention as well, and they're using the tool in that setting. That has worked really, really well from a colleague in the south, Ciara Kirk, who's the project lead in the south, along with Alpna in Scotland and myself in Northern Ireland. So the aim, Alpna's highlighted the significant problem with medication without harm. I think it's $42 billion per year is the value of the harm caused through medication inappropriate use. So Alpna's highlighted the 3 key technical documents: the medication in high risk situations, transitions of care, and in polypharmacy. So I'm going to talk about how iSympathy is hoping to address this issue with the system change. So the aims of the programme really are to deliver 15,000 patients across 3 jurisdictions, both in primary and secondary care, and also deliver training. I think Andy's mentioned, Alpna's mentioned education and training and development, very, very important, to 120 healthcare professionals, so GPs, hospital doctors, pharmacists, etc., with 40 in each jurisdiction, and also bringing cross-border collaboration and learning from material in Scotland and Southern Ireland, as well as in Northern Ireland here, to bring those all places together. So we've been working on that as well. So Alpna has highlighted the 7 steps. We're utilising this tool, and that will become the norm in Northern Ireland. And the department will be ensuring that that is utilised in any setting where we're carrying out a medication use. We will be carried out to this standard. And it's very important there's a patient-centred approach. So the steps are really what matters to the patient. So that's the important starting point. Identifying what are the key medicines, are there unnecessary medicines or beneficial medicines? Does the patient take the unnecessary drug therapy? You find that the patients adapt to what they wish to do, and that's why there's a very much patient-centered approach. Are we achieving what we're supposed to be achieving with the medications that the patients are receiving? Are they getting the benefits? And sadly, are they getting ADRs or potentially getting them, or actually suffering ADRs, which may lead to further medication prescription? Also, is it a cost-effective therapy, or are there other alternatives? Alpna showed some of the material, the nice smiley faces, very important for patients to make robust decisions about their medications. That you get 9 smiley faces, that's a good thing. Maybe 9 unhappy faces and 1 poor, that's maybe not a good product for that patient to select. And will the patient is willing and able to take the medication as intended? So it's very, very much a patient-centered approach. It takes time to undertake, but there's significant benefits. I'm going to share some preliminary findings that we have found in Northern Ireland at the end. So that's the key driver, and what will become the normal policy process in Northern Ireland, because there's been other medicines use reviews, term medicines use reviews, but you need to take the appropriate amount of time to deliver it correctly. So what does the review involve? Well, we identify the patient for review and then consent. the patient because we're collecting data, and the Scottish colleagues are analysing a significant level of the data sets, looking at social deprivation indices, high-risk medications, etc., to give us very robust data. So the pharmacist then in this project completes the patient history. Then the medicines review will be taken underway with the 7 steps approach. And we've used various, given COVID, the issues with COVID, which we've all had to deal with, maybe face-to-face, video consult, or by telephone. So using the different mechanisms which are appropriate also to the patient and also potentially carers. With full discussion and agreement with the patient about the process, why we're doing it, etc. And then there'll be follow-up with GPs in the primary care setting and hospital doctors in the case of Northern Ireland, also community pharmacists and other healthcare professionals as required. So we're getting that information right out to the multidisciplinary team in both sectors. We are undertaking robust data collection, and as we've mentioned, the Eden scale is a 6-point scale where you can record the importance of the intervention you've made. So we've used that for many years in MYC. So basically, if you score a 1, it means that your intervention has done harm to the patients. Thankfully, we have had hardly any of those, if any at all, up to 6 where you prevented fatality. So you can grade those interventions, and typically 75% of interventions made are grade 4, which improves patient care and above. So we're using that as a tool, and we can apply health economic value to that as well for those interventions, so we can get a return on investment in line with the sympathy outputs that Alpin had previously mentioned. We've also developed a patient-centered medicines appropriate index. This is based on the MAI, which was developed by Professor Hanlon in the VA system in America. And we've used that over a number of years. But as part of the process, we wanted to make it more patient-centered, and we worked with Professor Hanlon to develop this. And we're using that as part of our quality assurance of the process, and again, improvement. PROMS, again, patient-reported outcome metrics. Alpna has touched or highlighted the app that's available within the program, and that will encourage patient report their outcomes, their benefits, etc. So again, we'll be piloting that again in the hospital setting, and also will be used for colleagues in the South. That's very, very important to get that patient feedback and benefit from what they have been getting from their medicines. So the patient cohort are basically prescribed 10 or more regular medication, adults of any age approaching end of life due to any cause, including those with frailty. Age 50 and older in residential care setting, so that could be a nursing home, intellectual disability residential setting, or community hospital. And then on medication or combinations that are considered high risk, and Alpin has highlighted those in the A-pinch, such as bleeding, AKI, etc. And those are all defined in the Scottish Polypharmacy case find indicator. So that's sort of groups of folks that we're hoping to or recruiting within in the project. So that's what we've been doing. And so we've got to do 15,000 of these, so no problem there. We've got a challenge with COVID, so we're working hard to do that and deliver those. So I'm going to sort of focus on what we've done in Northern Ireland to date based on that. With the group regionally, we developed an ECHO program. ECHO is an American platform which is used extensively in Northern Ireland, also used in Scotland as well. And we developed a 1-year program for the pharmacists involved within the project. So that would be looking at case histories, then have a short presentation, sample of numbers needed to treat, a presentation that an interactive learning. Plus then we developed other programs, for example, how the psychology of managing patients, which were decided by the participants. So that has worked very, very well. We've had feedback from the folks involved, and we've now developed a year 2 program. I'll show you what that looks like going forward. So we actually created a community of practice, really what you were saying, Andy, in terms of what we're trying to create here. It's actually a community of practice with similar, and the ECHO has worked really well, and we're building on that. In addition, we've got accreditation now from the Royal College of Physicians with medical colleagues on the team, and that's accredited training covering the polypharmacy, the 7 steps review process, numbers needed to treat, and also change management and shared decision making. And that's available from Scottish Government on the TURIS system as well. So all this material would be available for sharing and going, so we're not reinventing the wheel, and we will utilize that going forward. So we're also, as part of the process within Northern Ireland, because we're going to use this as our regional approach, We're actually looking at in different areas now outside the program. Cardiometabolic pharmacists is part of an out-of-hospital team. We're working with the cardiologists in that area in the Western Trust. We're also going to hopefully put it into the cancer centres, working with the lead hematologists who run is key for that, and also with practice-based pharma to collect further minimum data sets. We have a very robust, comprehensive data set for analysis, and then we're also collecting minimum data sets as well for local use. Just said, so the ECHO program, the sort of things that they've divided for ECHO program in 21-22. These are sort of areas that we covered. So you can see skills and tools to manage difficult conversations, a day in the life of the iSympathy pharmacist from each of the nations to give the differences and similarities, etc. Managing and maximizing the impact of consultation. So these were devised with the programs, and those have all been created and are available with the material that goes with them, as well as the recordings of the meetings. So we have what's called Moodle, where we hold all the material. So again, that's available. So just to try and bring up some early findings, so that's all wonderful. What are we doing? Well, what we're finding so to date is the average number of interventions per patient is 9.1. So again, that highlights the numbers at ALTMA, scary numbers that ALTMA highlighted at the start in terms of the problems we have. We had 92.7 were grade 4 and above, which is higher than we would have thought. We typically aim for 75%. 4.86% is about grade 5, that's preventing major organ failure, and potential preventing fatalities 0.07%, which is encouraging, but also has an issue there. We've also been looking at the MAI score. So the lower the score, the more appropriate medication. So our PCMI score has typically been reduced by about 86% in these patients. Interesting is that I think the key point, the number of medicines before review was 12.4. The number of medicines after review is 12.4. So I think it highlights the point ALTMA was making. Polypharmacy could be appropriate and inappropriate. So you're not always going to see a reduction in medication. So it's important to highlight what's important to the patient and is it delivering what's in. So that's an interesting finding as well for us. The Eden grades will be converting into health economic values. So we want to scale and spread the system. So why would a health system do that? So the health economics and return of investment will cover the components that are related to medicine-related problems. It could be readmission rates, delayed discharge, etc. Those are things that we can pick up from that and give an overarching value. So these are some of the particular patients, the things that they found within the program. I'll not read all of those. You can see that for yourself. Patient on TAM solution and doxazosin, TAM solution stopped by GPs. When the patient was talked to, that they not usually taken together, GP told them to stop TAM solution. So the things that are starting to find out from that discussion. Targanac prescribed BT, that was on the Northern Ireland electronic care record. Took at night to help sleep, no indication for the pains, for they're weaned off it. So you can see a number of high-risk medications, and that's just a typical sample of the interventions and changes that have been made. And that will be reflected, that's a hospital setting, but there'll be other changes reflected in both primary care settings in Scotland and in ROI in the border counties. So that's the things that we've been doing, and they're linking into the multidisciplinary team. From the patient perspective, I think this is very important because if we don't get patients to engage fully with this process, it doesn't work. So again, I think there's a benefit of code we found in the hospital setting because of restricted visiting. The patients had no one to talk to. So in a perverse way, they were happy to chat to the pharmacist because they had quite a lot of time to chat. So we picked up a lot of other issues that we may not have done because of that, but it's worked out really well. For example, no one's ever sat down with me and taken the time to go through all my medicines. It means so much to be involved in decisions about my brother's care is non-verbal, and that was part of the groups we're looking for, and I do everything for him. So I think that the value from patients is very important. So if you get that buy-in from patients, you will then get the benefits from the patients and hopefully moving from that. So those are sort of key findings we found. Some form of doing much more robust analytics at the end of the project timeline. So really, that is really wanted to cover. I've given some contact details for iSympathy, the project, the website, and you can follow us on Twitter as well. I've given our MYC website address there. You can find us there. That's my own contact details. And again, our own Twitter handle. So again, that was just a summary. I think we'll finding the Southern colleagues' data is very similar, probably even better. And the GPs, you have a very novel service to GPs has worked very, very well. So Thank you, Andy.
I think that's fantastic, Mike. One of the nice things about this, and maybe one of the things I'd ask you to do, if you put the link for the iSympathy thing in the chat thing later, that'd be helpful.
Yeah.
Very often with projects, the criticisms laid out is that this never has any impact. Where can we see the impact of this? And I think what you've seen there, baked in, is impact, because you've started on the starting with the leading with the need, as we said right at the beginning of the conversation. Primary focus on patients. I think there's a clear impact, and I think that's valuable to see. So to see more of that information coming out, and we can again push that to our community, I think is vital, because that impact's important. It's important because what it helps then is adoption elsewhere, because people can see actual impact instead of suggested probable impact. And that's important because it gets rid of some of those excuses that people put up for, well, we might need to do another test, or I'm sure those people who've got blood pressure problems in Northern Ireland are completely different than those people in Scotland. They're not. Blood pressure is blood pressure, and the ways to treat it are pretty well known. So it's time then to think, well, we can use that in terms of helping people to think about how that can be scaled up beyond the project partner countries. And I think that's if there's one thing from that project I think we'd like to be able to see, is that be able to move out as an acceptable standard in other countries, because that's fine. Thanks for that. Conscious of time, if we could get the link to the project in the chat function, that'd be really good. We're going to jump on a plane really quickly, virtual plane sadly, and we're going to go over to Poland to hear from Lydia, who heads up both our Polish ecosystem, which is quite a new addition to our ecosystem network, but also has got some fascinating input from the Polish Hospital Federation, especially around the use of AI. So Lydia, the floor is yours. Thank you for coming on, and we'll hand over to you. If you could start sharing your screen, that would be helpful.
Sure, thank you. Thank you for the invitation. I'm really glad that I can be with you today here. I would like to say something about artificial intelligence, but also how AI can help with polypharmacy problem. Can you see my screen?
Yes, that's perfect. You make that lovely. Perfect.
Great. So my name is Lydia. I'm a managing director of Polish Hospital Federation and a leader of AI in Health Coalition. Towards about these organizations, Polish Hospital Federation is the biggest hospital organization in Poland. We associate together around, actually more than 500 hospitals right now. So it's a huge organization that works with public entities, Ministry of Health, e-health agency, but also with NGOs and private companies when it comes to a Polish healthcare system. Polish Hospital Federation was also one of the co-creators of AI in Health Coalition. It's a coalition that aims on implementing AI algorithms in healthcare system in hospitals, but not only in the hospitals. And it aims to do this in the fastest but most secure way, secure especially for patients. We have around actually more than 60 organizations in the coalition now. So first of all, I would like to discuss with you artificial intelligence. And we have like more and more discussions about it in Poland. And at the one conference, the president of our medical chamber said that artificial intelligence or developing AI is like a penicillin discovery. So that comparison shows us how strong or how revolutionizing this solution is. And three examples. Firstly, I would like to tell you about the algorithm that one algorithm can actually lower the false negative diagnosis when it comes to mammography and cancers about 7 to 9%. It means that only one AI algorithm can save like thousands of hundreds lives per year. And we are talking about only one algorithm. And I am always asked if AI will be used instead of, for example, medical doctor visits. And I always say no, but actually 4 years ago, that was the first AI algorithm that was accepted in the United States that actually could diagnose patient without the medical doctor. It's an AI algorithm for diagnosing eye retinopathy when it comes to patients with diabetes. But it's happening right now. It happened like 4 years ago, so it was quite time ago. And that there is a great newspaper about this digital health, the Lancet Digital Health, and I read there that, for example, they discovered or developed AI algorithm that could actually diagnose anemia, that patient has anemia, only based on ECG records. So it's something that is impossible for human, right? We don't diagnose anemia based on ECG records. And it all shows us how promising this technology is. And AI is not science fiction anymore. And the most important thing on this slide is that, like, around 5 or 6 years ago, we had like 10 times less AI algorithms worldwide. So you can see this exponential growth year after year. We have now, like, by the end of the 2020, we had around 450 AI algorithms that was certificated by FDA or CE certificate in Europe. So it's a lot, and it's like, you know, developing faster and faster. When it comes to Poland, AI in healthcare is right now very popular. We have that Top Disruptors in Healthcare report that shows us what our medical startups are working on. And actually the 3rd edition will be published in 2 months, but we can see now that the most important solution that startups are working on is artificial intelligence. And we created some reports about that, about AI algorithms that are implemented in Polish hospitals right now. When it comes to policy level, we have AI policy. It's not about AI in healthcare, but about AI in general. We started open data program, which is it's on the first stages, as I can tell you. We organize AI in health conferences and discussions about AI. And what's more important, our national entities, like, for example, National Center for Research and Development, creates a lot of grants and funding for solutions that are about using AI in healthcare system. Even our official website for patients under Ministry of Health used AI algorithms for actually telling patient if it is possible that he or she has COVID or not, and it was like officially implemented like 1.5 years ago. So it's really nice. But the most important question is how AI can help with the problem with the polypharmacy. And first of all, I would like to tell you something about e-prescription system in Poland, because we have like national e-prescription system that allows every doctor to give a prescription for patient through the national system. So we have one system that actually in the first half of year that it worked, it was like 2 years ago. 2 years ago, there was 300 million prescription prescribed through that system. And it's like the most popular system to prescribing the e-prescription. Like, you can always use paper, but nobody does it anymore. So it works like, it's a slide from our eHealth agency, but it works like that medical doctor prescribe an e-prescription. It is saved on our national system. It's named P1. And then patient receive e-prescription, and it can be received in the 3 forms, on your mobile phone or via email, or if we are dealing with, for example, elder patients, they can have like a normal e-prescription just printed on a paper, and it works really great, even if it's actually it's a new system because it works only for 2 years now. So limitation of that. So yeah, we are very proud of that system, but we are aware that there are some limitations to that system. And for example, that e-prescription system, the P1 system, secure only one-way communication. So we have that communication that is about medical doctor prescribing something and saving it to the system, and then system is communicating with, for example, pharmacy or a patient. So there is no two-way communication. Doctor during prescribing, during prescription of some drugs, doesn't have any tips or clues about, for example, what kind of drugs this patient is taking or took earlier. That system has a huge amount of medical data, and it's a great source of knowledge. And we are trying, and we have some first attempts for analyzing this data, but it's a great opportunity to see how e-prescription are prescribed and if patients are buying the drugs prescribed. And one surprising outcome, it's interesting, I think, that system, e-prescription system, helped our national organizations with, for example, searching for missing person, because we had the real data, like on a real time, that somebody got an e-prescription. So yeah, so probably there is more to add to it. And right now in Poland, we work on e-prescription 2.0. So e-prescription that allows two-way communication, and that allows actually usage of algorithms. We are talking about algorithms because we don't know if it will be, like really simple algorithm or it will be an AI algorithm. We will see. It will probably be developed in some time. But the idea about is that during the doctor is writing an e-prescription for a patient, it gets some information about, for example, what kind of drugs this patient took earlier, or what kind of drugs were prescribed to him by another doctor, and maybe some information about patient that, for example, patient is pregnant, so dear medical doctor, you should be aware of that, or this patient has an allergy for that drug that you are prescribing, so you should be aware of that. So we are talking about this two-way communication that actually should be very simple to implement, because we have that problem in Poland about hospital information systems that are like in silos, and they are not connecting with each other. But here, when it comes to e-prescription, we have only one national system. So it's really easy to connect them and allow this two-way communication. We don't have to have, for example, connection with hospital information system to give some additional advice. So for doctors, this communication could be like, Dear doctor, patient uses similar drug prescribed by another doctor. Be careful, or that drug interaction is dangerous. Be careful. Don't prescribe it. Or even if we have access only to the data collected in this P1 system, so e-prescription system, we can tell that, for example, a patient who has asthma should have prescribed the stronger drug, because he has acute symptoms like 3 or 4 times a week, and he's taking this drug, and maybe it's time to prescribe just a stronger drug, and it can be communicated during prescribing this e-prescription. For patients, on the other hand, it can be a communicate, for example, dear patient, be careful, because in 7 days the drugs will end for you, so you should go to the doctor, or your e-prescription will be outdated, so you have to go to the pharmacy and buy this drug if you want to. And I am happy to tell that it's not a science fiction anymore. Like it is still an idea, but we are working on it. There are some articles in Polish, I'm sorry for that, but we are working on implementing e-prescription 2.0 when it comes to, for example, patients with asthma, because we can tell a lot about them only based on the drugs that they are taking. And this two-way communication will be a great way to work when it comes to polypharmacy, and to alert the doctor when there is something going on that he should know about. So thank you.
Thank you very much for that, Lydia. I think fascinating, and I see from people's faces that I think we've heard many of our ecosystems people bring up the area of AI, but usually with little confidence. And I'm really pleased to see Poland leading the way on this, and we've been proud to be part of the and help sponsor the report, that Top Disruptors report. So I've put the link for that in the chat function. You could share any other links that you've got there for people, and please, I would be worried if you've got press articles that are only in English, seeing as this has been rolled out in Poland. So keep those articles coming, because I think this does say this is reality and not science fiction. So we've seen from the example from an iSympathy, and the need we've set out, we've had a little bit of future vision here from Lydia, and I think there's a great opportunity. There's a couple of events coming up on AI in Poland that we'll be distributing via our channels too, with colleagues, along with our Polish ecosystem. So thank you very much for your time. Stay around, because I want to have a discussion about how we start connecting up some dots. But before we do that, I want to talk and bring in a project that's been funded by the Innovative Medicines Initiative, which is now the Innovative Health Initiative, which is a BEMER project, which the ECH Alliance are proud partners of. We've got Ad here who's going to tell us a little bit about the project. Ad, the floor is yours. I'm conscious of time. Please introduce the BEMER project, and we're starting looking at another focus now. And you're going to be on mute, so press the mute button.
Hi everyone, Andy, thank you for the introduction. Can everyone see my screen?
We can, and it's going to be just coming up to a full screen, and that looks perfect. I think coming shortly. Brilliant. The floor is yours.
Okay, perfect. Well, today I'd like to talk about the BEMER project, which is focused on improving adherence behavior. And the previous speakers have already made us very aware about the size of the issue. Specifically, polypharmacy will make it even worse. My name is Aad Lieveld. I'm a member of the advice board at Link to Trial, and I'm co-leading together with Frans Volfort from Open Evidence the first work package of the BEMER project. We talked about non-adherence in the previous sessions, but I'd like to put some numbers and make it a bit more personal and closer to home. This is about 200,000 premature deaths each year for the EU alone, talking about 125 billion euros wasted money each year. And if you go to other regions, then you will see similar figures. So this is not only about 200,000 affordable deaths. This is about 1 million people dying each year because of non-adherence. Polypharmacy, Alpada had it in their presentation. We are in an aging society. We expect that the population will be 65 plus in 2030, and that will be 20%. Today, we're already at 10% of the world population. Now, here's some news for you. In Europe, we are already at 20%, and it will be even a lot bigger. Going back to Alpada's presentation, 65% of that 20% will have multimorbidity, meaning that the non-adherence issue is much bigger than we all see. So we didn't sit still as a healthcare industry. We made some improvements. First of all, in the past 10 years, we're talking about patient centricity, involving patient organizations into setting up treatments, into developing new pharmaceutical products. We have improved our patient information. We have tried to make treatments less burdensome, so it will be a lot easier for people to stick with the treatment. On top of that, we included patients doing shared decision making across the whole patient journey. We have apps sending out reminders to take your pills. We have smart pill boxes. And as we have seen, today we are very much focused on the intelligent polypharmacy. I'm not talking of appropriate polypharmacy, because if you think about that, we're focusing on the patient and what's important to them, and then align that treatment to that, making things a lot easier for them. But we're still having this ongoing non-adherence issue. So what did we miss? What we actually missed is that we're talking about people behaving in specific situations. And in 2003, the World Health Organization already put us on that track. In that report, it actually says that the missing piece of the puzzle is actually behavioral science. There is an option to segment the population, patients, people, based on their needs and limitations. And based on that, we could provide them a much better support. And if you align that support to their specific needs, then we're closer to home. And we also have to understand that non-adherence is not a constant. It's a dynamic process. It could change day by day. Depending on the situation you are, your behavior will change. You have seen that in any other situation in your life. So personalized interventions, support is critical. As you can hear, I'm not talking about the patient any longer. I'm talking about persons. So in 2020, the FPA started, and IMI started drafting the call for proposal for this project. And last September 2021, we kicked off the project. Unfortunately, because of COVID, we could not have a face-to-face, so we did this virtually. So we're now in the first phase of the project, which is run by the University of Porto together with Pfizer. It's a European initiative. There's a consortium built for this project consisting of 30-something organizations, part from the healthcare industry, part from the pharmaceutical industry, part from the academic world, and even some technology providers and service providers like my company, Linked to Trial. So we have set a goal, and what we hope to do in the coming 5 years is to deliver a model based on human behavior that enables us to predict adherence behavior based on profiling, and based on actual factors. And actual factors are very important because, as Andy already said, result is what counts. If we want something to be adopted by the rest of the world, then we need to come up with proof that this actually does the job it's intended to do. So we're focusing on these actual factors, meaning that if you change these factors, you actually will change adherence behavior. To be clear, we'll come up with a model, not actual solutions. That model can be used by other companies, by pharmaceutical companies, by healthcare companies, by technology partners to build solutions that will enable healthcare professionals to provide better, more personalized support. And the other thing is, because based on the results and the experience we have with this model, we hope that this will feed back into the R&D cycle and starting to build, create products, treatments, services that from the start are much better aligned to the limitations and needs of the patient, us. So how will that look like after this project? We'll have this model, and on the left you will see that we can group patients based on that model. Based on that grouping, we could align our products and our services to their specific situation per group. That will be the basis of creating tools, environments, digital support, create better patient-focused information, personalized information, and decide on personal interventions. On the right top, you will have the patient. Through a questionnaire, they will provide us the information that shows us which type of patient they are, and if we understand that, then we know how we can support them the best way. Andy already mentioned that, and I believe Michael showed that. One of the feedbacks, of some of the feedback, was very much focused on how happy people were with the communication between them and the ACP. Communication is very important, and thinking about patient information, putting that in a form that is aligned with the patient, their profile, will have a better effect on them. So how will we reach this goal? We have structured the project in 6 work packages. Today, we are in the midst of the first work package, which is about collecting all information that's out there about existing models and the factors that are involved, focused on adherence behavior. Based on that, we will do an analysis and make a decision on a most feasible model. Again, we're not looking at 100% improvement of the situation. We're focusing on one step forward, making a difference for the patients and for the ACPs. So if you can make that difference, improve the situation by 10%, that's 10% more than we did in the past 30 years. But let's hope that we do more than 10%. The next step will be that we'll collect any data we need to substantiate our decision or choice, or any data we need for the 4th step, which is validating the model. And with validating, actually that's where we will prove that this model will predict adherence behavior, and based on the actual factors, you can actually improve the situation. That's what the proof, what Andy was talking about. This is the model we chose. We validate that. We prove that it actually does what it needs to do. And then we have the implementation strategy, meaning that we will draft a guideline on how to use the model, how to train people to use the model, how to use the model to build solutions on top of that. How to use the outcome of that model in the R&D cycle. So in every step of the process, we'll see how you can use the model, how you can implement the model, and how you can benefit of that model. Now, this is a project, and each project has a start and a finish. But we don't want to finish the Beamer model. So in work package 6, apart from project management, we'll create a sustainability plan. So we'll keep it alive. And by meaning keeping it alive, we'll have the whole data set available. We'll have a support organization, and we have people involved from all our key stakeholders. So as I said before, we're focusing on real world benefits. This is very important. Not a theoretical model, not something that after 5 years we have to say, okay, we need another project to figure out how we can actually use it. No, we hope to actually deliver benefits by the end of this project. As I said before, we're not creating solutions, not off-the-shelf solutions. That's for the rest of the world. We're also not focusing on profiling ACPs. Some may think that that could be done. Well, maybe it could, but we won't do it. So who will benefit from that? Important. We have defined a number of key stakeholders. The first one are the ones that will have a benefit on a day-to-day basis. These are the key stakeholders, our patients, their caregivers, the healthcare professionals, but also the pharma industry. Because the pharma industry develops new products. And if you go back to the clinical trial environment, you already see that we already have an adherence issue. And it gets worse if we go to market. One of our colleagues in the Beamer project said, in the trial environment, we have little issues with adherence, but the minute we go to market, it drops below 50%. To me, it says, well, then there must have been an adherence issue before. We just didn't see it. So what are the benefits for each of these key stakeholders? The patient, not the patient, the individual, the human being, you and I will be treated as a person, not just a patient, not focusing on your condition. You would therefore feel acknowledged, feel appreciated, and you will get the right support at the right time. But not only that, also at the right level. What about the healthcare professional? We will provide a better understanding of the potential adherence behavior. We'll provide them an environment that could help them align their interventions with the specific patient's situation, the personal environment the patient is in at that moment. Meaning they will be more effective. They will have more information of the person across them. They will have a better understanding. What about pharma? Well, as I said before, all that information will feed back into the R&D cycle. And then hopefully we can start creating new products, new treatments, focused on the best adherence potential from the start. Now, this is also about why we like to have people involved like you. Our success, the Beamer success, very much depends on one thing. It actually needs to do what it's supposed to do. But the other thing is people need to actually use it in the field on a day-to-day basis. If we don't provide that, then don't bother talking to government organizations. Don't bother talking to insurance companies, because what's in there for them? Nothing. So we have to provide that proof that we provide benefits, cost cuts, better patient experience in the field on a day-to-day basis. That will convince the rest of the world to adopt and integrate that into healthcare systems. What we'll offer our stakeholders is to share their perspective. Up until now, it's mostly about us. We go back to the literature and we see definitions on adherence. We go back to our experience and we see, from our perspective, actionable factors. But how does the patient look at this? What is adherence to them? What is actionable for them? What are their needs and wants? And as I said, we will validate the model. Well, if you want something out of that, then getting involved in the BEAMER project will provide you the opportunity to actually secure these benefits by providing your perspective, by securing the validity, by helping us make implementation more successful and more feasible. And by the way, this is not about organizations. This is not about other patients. This is about you and me. Because at one point in time, we will either be a patient, or maybe you already are, or a caregiver. So please do share your opinion. Help us to get that shared definition of adherence. Help us identify actionable factors. Help us prioritize. Help us validate. In short, help us out. Okay, and if you want to have more information, there we have a number of things. We have the website, we have a LinkedIn page, beamerproject.eu. That's the URL where you find more information. You can reach me through the BEAMER project, or you can reach me on my LinkedIn email. Thank you.
Thank you for that, Ad. We've put the links for the BEAMER project for LinkedIn and Twitter in the chat function. So people can follow you on social media and find out more information about you there too. Thanks for that. I think a really comprehensive picture of the value of the approach within BEAMER. Now then, I'm conscious of time. We've got less than 15 minutes. My first question is, as always with these things, we've heard from 3 exciting initiatives, from the initiatives between Scotland and Northern Ireland and the Republic of Ireland. We've heard about the future happening now within Poland, and I'm conscious Liz just had to step away. But we've seen, I think, a really comprehensive package within BEAMER with some great project partners we're proud to be part of as well. My first question is always, so what? Where's the collaboration potential between the 3 of you? Okay, that's my first question. Where can we collaborate more from what we've learned today? Mike?
I can start that. Yeah, I think even I'll start with data, perhaps even, and Lydia's presentation, particularly with the whole e-prescription system. Because certainly here we've been looking at, we have a data group now, the issues of getting data, but we have a data group now for medicines. We've established in the province to look at all the data sets that are available. We have our e-PAS system, so there's lots of medicines data. And equally, Alp and I have been chatting about that as well with a colleague from in England under the HDR UK, the health data. So, and I think the data that, there's a tremendous opportunity there to look at that. And I think that fits some of the stuff that Ad was talking about in terms of identification or stratification of patients. So via medicines use and linking to diseases. So I think that would be one thing that could be done. And
that's one.
Yeah, that's one. Okay, that's my starter one. A second, obviously, I'll let Albert go. Obviously, the connection between adherence and the patient-centered medicines use review. There's clearly connections there in terms of, because it's the patient-centered approach. You're going to get the patient to work with their medicines or adhere to their medicines or concord with their medicines much better because you've talked to them in a sense. I think that's what you were saying. That is what I could be a patient, what you or I want, but you've actually articulated that, and therefore they'll use their medicines and therefore adhere to it. And things like behavioral, we've looked at some work on BMQ, the BMQ questionnaire. We saw benefits there in an adherence piece we were looking at. So I think there's a connection there. That's 2 for me.
I agree. It's if I look at the iSympathy project and the push because of polypharmacy and an aging society, getting to being able to understand where the patient is, because as I said, adherence is a dynamic process. And we could definitely add something extra to the sympathy project.
Okay.
Because if I look at the app and what sympathy does, it makes information more accessible and more understandable. But at the same time, I also see that we need to align our way of communicating with the patient to their actual situation at the moment. So having a better understanding of where they are today or tomorrow, and aligning if I need to bring that message or someone else. You see it with our kids. You can say a lot of stuff, they just totally ignore you, and then some friend of them just says the same thing and they do it right away, or a TikToker. So depending on that situation, working together, I see only benefits.
Okay. So there's a challenge for you both. I can see an interactive meeting between the Beamer project on the one hand and the iSympathy program on
Yes.
the other. So we'll look forward to being invited to that one to find out more. Alpana, I'm conscious you had a question. I can see your hand in the
and not really a question. I suppose
sorry.
just commenting. I would totally agree. So there are some quality of life questions in the patient reported outcome measures as well as the 7 steps. So I would hope that what we learn from iSympathy, that we can maybe sort of feed that in, and vice versa, we can learn some lessons and take that back into some real life implementation. So I look forward to working with Beamer further on this anyway. I think it's a great opportunity. I think that you hit the nail on the head, and one of the things that we've looked at a lot is how we use nudge theory, behavioural, using the human factors elements of how we get clinicians to do the right thing. But the most important person, I think, here is the person, the patient, the individual that's making those decisions quite often on their own. They're taking lots of information, and how do they decipher all of that? And how do we help them achieve what's really crucial to them at the time? So that's really all I wanted to add.
Actually, I can add to that Alpana is already at one of our advisory boards. So we are, in fact, already working together, but we definitely need to make it a lot broader and maybe more detailed in the different work packages. Let's work on that.
Absolutely.
Excellent. Any other questions from audience? Please put them in the chat function or raise your hand. The other question I've got is what is your specific ask for colleagues here today?
Well, we have within work package 1, we starting up the stakeholder consensus and information cycle. And we will plan interviews with our key stakeholders. Pharmacists are, to me, on the side of ACPs. They are part of the whole process. So I would think that your input on subjects or topics like what is adherence from your perspective, what is actionable from your perspective, is essential. That input will help us improve the model. The other thing is, the same goes as Annie said before, we're not looking for a theoretical model, we're also looking for a implementable and a model that's actually used in real life. So think about, help us out in how can we make this work for you as a pharmacist. What type of needs do you have out of this model? What information? I'm not promising that we can do all of that in the next 5 years, but it's a simple thing, like if I build a house and I forget that I need a kitchen, yes, I can do that afterwards, but you all understand how the house will look like. So having that input from the start will help us create that fundament where we can build on, let's say, for Beamer 2.0.
Okay, thank you for that. Any other input?
Yeah, no, I think that's great. I think it would be interested and involved if we've tried to do sort of real world evidence, or so like a post-discharge follow-up from hospital with patients, you know, or carers, that we were able to reduce readmission rate in those, particularly with those specific patients, but focusing on those components, as well as, are the medicines still okay when you came from, which is our theme. I'm rolling into our next trailer for our next program, Andy. This is part of the transitions of care piece, but the part of that piece is also talking to the patient, have they settled back in, etc. So there are benefits there. I think that's important. The other angle, I think you'd mentioned digital. Everybody mentions digital ad. So I think there's a lot, the Shapes European project we're involved with, we're looking at medicine supporting older citizens in their own homes. So, you know, there's an element of that ad you sort of mentioned, not to, so we're looking at how that fits, but also the digital literacy of the older citizens. So their ethnography, etc. So there's something around that. So there might be a connection to the Shapes project. We're looking solely at the medicine space, which fits us, but there's others looking at neurodegenerative disease, rehabilitation, etc. So there may be a link on the digital side where that fits in appropriately or not.
I agree.
Just before we've actually got a question from the audience here as well.
Okay,
we'll come back to you in a second, but I'm gonna have to get my glasses on because I can't see both. How do you address, understand? How do you address the issue of inclusivity and accurate representation of marginalised communities to ensure that the tools you're developing help them as well?
Is that a question for the Beamer project?
Both. So you first.
Well, what we do, we have involved a number of patient organizations. I mentioned the validation process. We will validate the model across 6 different disease areas. Despite we say it's disease agnostic, but then again, we still have to make sure that it actually is. And by validating that across 6 disease areas, we hope to do that. Because we do that, we also involve the belonging patient organizations. And what we do in work package 1 already is, I mentioned the interviews and maybe the focus groups, but we'll change the questionnaire we now have for the interviews into a closed question setup. Distribute that across the patient organizations to their members. And by that, we'll have that representation across the whole of Europe.
Okay.
Yeah. Similarly, in another piece with the Shapes project, we'd worked again with community and voluntary groups, again, crossing the spectrum of to be as inclusive as possible. So we'd work with, for example, the Mid and East Antrim Aging Well partnership, which was connected and looking at whole areas of that. So again, a very similar approach to that, working with community and voluntary people who can bring that inclusivity to the project. So no one's marginalized and can benefit from some of the changes that we're making.
Okay. I'd like to add something to that. We talked about inclusivity. There is a group that is disconnected from us, the healthcare industry. In our terms, we call them the very non-adherent patients, or maybe we should name them the hard-to-reach patients. We're talking about people that simply lost beliefs in whatever we do. In our minds, they are non-adherent simply because they don't do what we ask them to do. In their mind, they may be very, very adherent to something else. We'll make a specific effort to reach out to this group and to help us understand why they disconnected in the first place and how we should improve ourselves in their mind. So that's the other missing piece in the inclusivity.
Okay. Vital. Now I'm conscious of time. This is the first of a step. Obviously, today's been fascinating review from across 3 programs. We're going to look next at the area of transitions of care. Mike, tell us what your ambition is with this.
Well, I think we'll try and sort of, Alton has highlighted from the WHO challenge a major problem, and that's 30% of errors occur at transitions of care, not only from say a nursing home to hospital or back, but also even people going from intensive care to another ward. There are issues there. So there's a whole raft of problems at transitions of care, and we want to sort of again address those, the scale of the problems, what sort of solutions are there, and how can we add that component into achieving the overarching WHO global challenge. Obviously the third one will be Albans had high-risk medications or high-risk situations. So it's a logical theme there, and we could then see what we can. So the transitions occur the next one. So obviously there could be electronic transfer of information. What can we do? What are the challenges? What have people been doing? And then can we again get right across the ecosystems? Can we learn from each other again? And I think that's the important thing from this piece as well. Get this on, see other folks can come see the material, get it together, and how can we work together, learn from each other, or else develop bids under the different schemes to address where there isn't the gaps in the knowledge, you like, and replicate that. With transition occurs a major problem as well. So replicate this approach to this. Then we have so many folks across the is it 80 plus ecosystems now, and it's maybe grown with a massive capability there with people with similar interests.
I think, well, we've seen today, I mean, we've got input here from Northern Ireland, Scotland, and the Beamer project and Poland, but even within the Beamer project, we've got ecosystem partners there from Norway, from Portugal, from a wide spectrum across our community. So I wouldn't think that.
Yeah. I think we're going to, there's a cost action called Enable ad, you probably know, so we're attending that next week. So again, there's a lot, we've only just started, we just joined that, but again, there's a large number of folks there who clearly would have a lot to contribute. So that's what we need to join up.
Yes. Yeah, we need to start connecting some dots on this, and I look forward to sending out details for our next session. And we'll be in touch with you. I'd like to thank all our speakers. Alpina, thank you very much for coming along. Ads as well for your presentation on Beamer. Lydia for the input from Poland, and Mike obviously for giving us that insight into the iSympathy program. I think it's valuable for all of us. Thank you for your time and your questions and your inputs. We will share all the resources we got from you from today, but also anything else we'll put on the website that comes with this thematic innovation ecosystem. And obviously we'll be sending out a recording of this to the rest of our audience and for the rest of our community, because obviously there's we find out one of the nice things with Zoom, the Zoom culture thing is we have more people watch these things after the event on catch-up TV, which for me, you know, when in the good old days with conferences, you couldn't imagine of sitting there with a microphone and taping the conference and taking it off to share. So thanks from me. Thanks for colleagues from Lease Excellence for your support, Adriana, Ines, and Anthony as well. And we'll speak to you soon. Thank you very much.
Thanks, Andy. Thanks, folks. Okay.
Okay. Thank you for the opportunity.
Okay.
Bye.
Bye. Bye. Bye. Nice to meet you both.
Bye.